Vores næste taler, han er fra Holland. Albert Dahan, han er formand for Leiden University Medical Center, og vil give et indblik i de forskningsprojekter, der foregår i Leiden, og det er ikke så lidt, skal jeg hilse at sige. Og vi har jo den vinkel med netop, fordi som flere har været inde på, at det næste skridt for dansk forskning er jo, at man går internationalt, for at starte nogle samarbejder med andre universiteter, som måske har andre perspektiver, eller i hvert fald flere erfaringer, end vi har i Danmark. Efter Albert Dahans oplæg, der vil Marianne Hundtofte Nielsen stille spørgsmål til oplægget. Marianne, hun er Chief Commercial Officer for over Nordic Cannabis, og så er hun næstformand i den nye brancheforening for cannabisproducenter, MCI. Og I kan selvfølgelig også selv stille spørgsmål, det kan I gøre via Slido. Og så vil jeg bare overlade ordet til Albert Dahan. Albert Dahan, thank you very much for participating and sharing your experience here.
Good afternoon, ladies and gentlemen. My name is Albert Dahan. I'm an anesthesiologist at Leiden University Medical Center in Leiden in the Netherlands. And I had a large research group that studies perioperative outcome as well as pain management. And one of the projects I'm involved in since some years now is the treatment of chronic and especially neuropathic pain with cannabis and related products. And I will be talking about that. Let me share my screen. And let's put it on full play mode. Well, I will be talking about studies that we have performed in recent years, as well as on studies that we will be performing in upcoming years. This is the hospital I'm working in, the Leiden University Medical Center. It's a relatively modest hospital. It has around 9,000 people working in it. I have to say most of them work in the care setting, but around 40% of people work in research. I'm extremely glad, and hope you can see it, that we recently obtained 2 very large grants to study medicinal cannabis in chronic pain. I will be talking about that a little bit. So we are a research group that initially only studied opioids. I started working at Leiden University Medical Center in 1987. I did my PhD there. I did my residency there. Afterwards, I became a staff member and a professor of anesthesiology. And we started initially studying opioids. And we looked at the benefit and risk of opioid use. And we moved slowly on, starting in beginning of this century with research into psychedelics, most importantly into ketamine. We published quite a lot. I have now over 50 publications just on ketamine. And only recently, around 5 years ago, we got interested in cannabis and related products. And we started a strategic collaboration with one of the growers in the Netherlands called Bedrocan. I'm sure most of you know them. And they funded one of our first publications. I will get back to that later. And also 2 other trials that I will be discussing later on as well. And we're not restricting ourselves currently to cannabis and related products, but we are also looking at other psychedelics such as LSD and psilocybin. I will not talk about that today, but it's also quite a very, very interesting field of research that we just recently started. So the first study that we did was initiated by Bedrocan, I have to say. Well, to be honest, they did not approach us initially. They approached the Department of Psychiatry to study the effect of cannabis in depression, anxiety, stuff like that. The psychiatry department involved us, and we moved on quite quickly to study not depression or anxiety, but we did include those endpoints in our study, but our primary endpoint was pain relief. And we were very interested in studying chronic pain patients rather than volunteers. And we were looking at a specific population of pain patients that was readily available. We have a large population of so-called fibromyalgia patients, which is a form of chronic musculocutaneous pain. Very difficult population. We did lots of studies in those patients, and we know that around 40 to 50% of these patients have small fiber neuropathy. So it's a very mixed population, and we really wondered, first of all, whether we could do a study on cannabis in this population, and we also wondered about the results of this study. So we've performed what we called an experimental randomized study. As you can see, these are the authors on the publication. We always involve a PhD student. We involved the head of our pain clinic, which is Marieke Niesters. We involved the company, and we were very keen on their presence on the author list. We have our data analyst always there, and there's me and the manager of the study, in this case, Monique van Velzen. The right side, you see the complexities of the disease, fibromyalgia. We decided to study 20 patients. We wanted to keep it small, but every patient came back 4 times. And what we did in this study, that every patient was exposed to 4 varieties of cannabis. And we used the volcano, so we used inhaled cannabis. As you can see here on top, this is Tine van der Donk, our PhD student, inhaling just air in this case. But this is how it went. We used the volcano to vaporize the cannabis plant. We used the flower. And we had the subjects, the volunteers, which are in this case patients, inhale the cannabis in, let's say, 3 to 5 minutes. And it went quite easily. We studied 4 varieties of the cannabis plant, as you can see it here, beta-rocam, bediol, bedrolite, and a placebo variety, which was absolutely derived from the plant. But the active components, THC and CBD, were extracted, were removed from the plant, so we just had the terpenes. And we had 3 varieties with a varying level of THC and CBD. So we had 1 variety which was high in THC, the beta-rocam variety, and 1 variety which had both THC and CBD, and 1 variety that was low in THC but high in CBD. So we worked with these 4 varieties. Every subject, every patient came back once. It was a blinded study. So the balloon was also blinded to us. We could not really see what was in the balloon. Every subject came back 3 times, like I said before, and inhaled the products that we produced on the morning of the study, I have to say. So all medication was quite fresh. Well, we've performed a pharmacokinetic study as well. So all subjects had an arterial line from which we took blood samples. Currently, we're in a position that we can measure these concentrations ourselves. But at that time, they were measured in a commercial lab in the Netherlands also. And as you can see on the left, so we have the variety beta-rocam with high THC, and which is in green, and in blue you see the metabolite 11-hydroxy THC, and we see almost no CBD present. In the middle, bediol, that had much lower concentration of THC inhaled, but you can see again in green that the concentration was not that far off from the CBD concentration. Very interesting observation that if you combine the two, the THC concentration in plasma increases. Again, in blue, the metabolite, and on the right side, you can see the variety that had just CBD, almost no THC, but still there was an appreciable amount of THC present. Interesting observations already, but let's go to the results of this study. On the left side, you see the spontaneous pain scores. You need to realize these were patients that had pain scores of around 5 to 6, some even 7 or 8 spontaneous pain scores. In the middle, and this is something that we always do, we always apply experimental pain models to our patients because we have the impression that the placebo effect is much larger in the spontaneous pain reports than in the experimental pain reports. And we always also measure toxicity. In this case, we had several, but in this case, I present to you drug high. And as you can see on the left side, that was difficult to obtain an effect larger than placebo. Placebo is in purple, because it was an appreciable placebo effect. But if you look to the red line, the Bediol, the one that combines THC and CBD, was an appreciable. The largest effect was there. This did not reach the level of significance. Pressure pain did reach the level of significance in which the Bediol variety was significantly more potent than, for instance, placebo. And the same applies to the drug high. We observed a significant drug high effect, but the drug high effect is quite modest because this is a scale from 0 to 100. And we reached around 40 on a scale of 0 to 100, which is around 40%. And if you compare this, for instance, to ketamine, which is also psychedelic, then in terms of drug high, you reach values of 80 to 100. So it's a mild drug high effect. So the psychedelic effects in our study was relatively mild. And you can see in purple on the right side that placebo, for instance, had no drug effect. So these effects were significant, except for the spontaneous pain score. Now, again, pressure pain, you can see that the Bediol variety that contained THC and CBD had an appreciable effect, which is quite a large effect, because what we do, the pressure pain, we perform the pressure pain by pressing a weight on the area between the thumb and the first finger, and it's quite painful in these fibromyalgia patients that have mostly muscle pain. So the fact that we could press around 10 to 50 Newton here is an appreciable, it's quite an appreciable effect. So we were quite happy with it. Now, if we look at the spontaneous pain scores, we also looked at the responder rate. These are responder rates. And on the left side, the 30% responder rate, on the right side, the 50% responder rate. And you can really see that the Bediol variety had a relatively high 30% responder rate. So almost 90% of subjects, pain patients, had a 30% reduction of their pain. And realize that in real life, for instance, with opioids, but also with antidepressants and anti-epileptics, and a magnitude of pain reduction by 30% is quite common. If you look at all of the trials of these neuropathic pain treatments, you will find that 30 to 50% of patients have 30 to 50% of pain relief. So in this sense, the Bediol variety was not very different from what we observed previously in other treatments, but the side effect profile was much less. So that's an important one. Now, we did some pharmacokinetic, pharmacodynamic modeling. On the left side, we plotted the plasma concentration to effect for the three varieties. Of course, placebo cannot be involved. And we did some complex modeling on the right side, in which we have the estimated, the presumed brain concentration versus the, and in this case, what we plot here is the experimental pain, the change in pressure pain. And if you see on the red, we have the Bediol variety that contained both THC and CBD. And you can see that despite the fact that only 13 milligrams of THC was present in this inhaled drug, the effect relative to the Bediol variety with 22 milligrams of THC was much larger, both in terms of effect site concentration and in terms of effect. So the combination of THC and CBD has some effect, while CBD itself in green, of course, did not increase the THC so much because there was almost no THC available, but had a very small effect, around half, in most subjects, even a third to 25% of the effect that we observed with the Bediol variety. Very interesting observation. So to conclude from this first study, we saw a high efficacy from two of the THC containing variants. So the one that contained both THC and CBD, Bediol and Bediol, with the highest efficacy in the ones that had the combination, especially on experimental pain. So we concluded from these studies also that the presence of CBD in the inhaled compound increases the uptake of THC. That's an important observation, and we believe there are several possibilities there, either in the presence of the combination, CBD might be cycled towards THC. That is possible. I don't think so in our experiments. I believe that the CBD enhanced the THC uptake through an effect on pulmonary flow, blood flow. So an increase in pulmonary flow causes an increase in uptake. And to really further study this, you should measure cardiac output in this subject, but that's for future research. On terms of the efficacy, we had the impression that CBD and THC were somewhat antagonistic, but I have to say, because we're continuing analysis of these data, that in a reanalysis of these data, the question mark is more or less a negative. But, and this was a little bit disappointing, in our hands, CBD was without effect on pain relief. You need to realize that. So we continued our research. And as I said, we obtained a large grant from the Dutch government. And we formed a consortium called TAP2, Tackling and Preventing the Opioid Epidemic. And to study the opioid epidemic and to get as many patients away from the use of oxycodone, we're allowed to perform this study. It's again a relatively small study in 60 chronic pain patients. Again, we went for fibromyalgia patients, and we studied the interaction between oxycodone and Badiol, the variety that contained both THC and CBD, on chronic pain. But the aim of the whole study was to reduce opioid side effects. So the whole study was powered on opioid side effects. We studied cannabis-naive patients with fibromyalgia. The whole study was performed, or currently is performed, I have to say, at home. There's 6 weeks of treatment at home with the inhaler. So again, we're going for inhaled cannabis, the so-called Mighty Medic. I've shown it here. And we use small cups with cannabis. And the pharmacy fabricates these cups. They're very, very similar to Nespresso cups. So every patient gets around 300 cups, and they're allowed 5 inhalations per day for six weeks. And there's 1 month follow-up in which we're going to look at especially the oxycodone effects that, if present, should be reduced in patients with cannabis inhalation. Endpoints are pain relief and the craving-related symptoms during follow-up. We have 3 groups. The first group is oxycodone, just oxycodone, 5 to 10 milligrams per day. The second group combines oxycodone with cannabis with up to 6 inhalations per day. And the third group is just the cannabis group. Well, we're now up to 50% inclusion. We need to realize it's a complex study with very strict in- and exclusion criteria. So we do lots of phenotyping prior to inclusion. I've shown you the groups there. And what we observed, that we had around 20 to 30% dropouts. We relate this to the fact that most patients are cannabis naive. We saw some side effects in this population, especially headache. And we also observed some anxiety, not related to the treatment itself, but to the fact that we're currently performing a study like this in the COVID epidemic. There was lots of anxiety related to fear of infection, etc., etc. And we have to say, if we look at the group that has the combination of oxycodone and cannabis, the maximum dose of treatment was never reached. It was quite interesting. So for now, in the first 50% of patients, there is trends towards an appreciable positive effect. Recently, we got our second large grant, and this grant is especially aimed at studying cannabis for chronic pain, medicinal cannabis. This study is performed with a research center adjacent to our hospital, and they will be performing the first study, which is performed in healthy volunteers. It's a double-blind placebo-controlled testing. They use a test battery, pain battery. We will be doing PK metabolomics. And what we want to know from the first part of the study, which compound, THC, CBD, which combination to be used in our patient, and also which dose to be used in our patients. And the second part, quite a large study in 200 chronic neuropathic pain patients that will be tested in a double-blind fashion, in a crossover design, again, with strict phenotyping. So we have strict in- and exclusion criteria. based on QST, quantitative sensory testing, and based on CCM. We're looking at the cornea, because in the cornea you will find small C fibers. It's very easy to detect, and we use that as an indication of the presence of small fiber neuropathy. We will be performing a crossover study. So all patients will be dosed from 5 to 6 weeks. There will be an appreciable 2-month washout period in which they will be redosed either with the cannabis variety tablets, we're going for tablets this time, or for placebo. And we're really aiming this time at pain relief, quality of life, socioeconomic effects. For instance, are these people able to go back to work? Well, finally, I would like to discuss a toxicity study that we're planning, again with Bedrocan, in which we will be looking at the combination of cannabis and oxycodone on ventilatory depression of ventilation, because we know that the cannabis varieties, all of them do cause some sedation. We all know that oxycodone is one of the main reasons for high fatality in the US due to opioid misuse, abuse, but mostly due to the combination with other products, for instance, with cannabis. We have done similar studies with, for instance, we did a study with oxycodone and ethanol, alcohol, and we observed, especially in the elderly population, that the tendency towards severe respiratory depression with even cessation of breathing increased significantly. So this is an important study that we will be doing next year. Well, I would like to end my presentation with some comments that I obtained on my first study that was published in Pain. This is a comment from Canada, and I received it a little bit more than a year ago, just after it was published, and it states, the paper in Pain examining pain response is outstanding, blah, 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 blah. I'm a rheumatologist and pain medicine doctor and head of therapeutics committee of the Canada Rheumatology Association, and we've just published a position paper with pragmatic advice regarding medicinal cannabis, and she likes the paper. It was a she. Really important. Then I got another mail from a physician in the Netherlands, and he stated, I just saw you on TV, national news program. Please let's discuss on short notice cannabis. It's obsolete as the remarkable drug oxycodone. So this person sees cannabis very similar to oxycodone. I would like to discuss your research in patients with unclear clinical diagnosis and very short follow-up, blah, 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 blah. So you see, there are two groups of physicians worldwide, I have to say, ones that are open to new developments, that are open to new research. And I do agree, our first study was a small study. It was a proof of concept study. It was a feasibility study, a small PK/PD study. And there are others that don't like those kind of studies. They're very, very much afraid of drugs like cannabis, but they're evenly afraid of drugs like ketamine, psilocybin, and LSD, because I approached this group also for studies with psilocybin or LSD. Quite interesting. Well, I thank you for your attention, and I think the time is now for questions.
Professor Dahan, thank you very much for a nice presentation, and as always, right on time. So thank you very much. We do have some questions from here, and one of them I would like to ask you is about your funding from the government, which maybe could be interesting for us here in Denmark to know how you had that collaboration with the government.
Albert, there's no sound on you. Can you? Yeah. The sound is gone. It's still no. Sorry. There's no sound at all. Okay, yeah. We're working on it. Is it... Yeah. No sound. No sound yet. They're working on it though. Ja. Okay, mens vi venter på lyd for Albert, så Marianne, så har vi faktisk et spørgsmål til dig til industrien. Så det tænker jeg, at vi lige tager, mens vi venter på Albert, så fikser de lyden imens. Jamen det handler om, der er en, der skriver vedrørende manglende klinisk data. Hvad er egentlig cannabisindustrien strategi for fremtiden her? Og hvad betyder det noget, om der er regulering eller ej, før I kan gøre noget? Og når jeg spørger Marianne, så er det jo ikke, fordi hun sidder i Aurora kun, men fordi hun simpelthen er del af brancheforeningen for medicinsk cannabis.
Jamen altså, vi er jo selvfølgelig interesseret i at støtte de her studier, når vi kan komme til det. Men det, der er i det lige nu, det er, at vi har jo ikke fået godkendt nogen dansk producerede produkter. Og før vi ved, om vi har nogle produkter, vi kan tilbyde til forsøgsordninger, så kan vi sådan set ikke rigtig støtte forskningen, fordi det giver jo ikke mening på nuværende tidspunkt. Men vi håber selvfølgelig snart, at vi får nogle godkendte danske produkter, og så skal vi selvfølgelig tage det her op igen. Og det er jeg da sikker på, at vi alle sammen gerne vil.
Så I kan ikke gå ind i forskning, før der er produkter på markedet, kan man sige? Altså,
vi er jo nødt til at være sikre på, at de produkter, vi producerer, lever op til de standarder, som der er. Ellers så kan man jo sådan set heller ikke få godkendt sine kliniske forsøg, hvis produkterne ikke er godkendt til det. Så det hænger ligesom sammen, i min optik i hvert fald.
Ja. Det er super. Tak for det svar, og tak for det spørgsmål. Er der lyd igennem til Albert? Nej, det er der stadigvæk ikke.
No sound, Albert. We are so sorry.
Ja.
Yeah.
No sound.
So
let me try again.
Okay.
Something happens now.
Yeah. Yeah. No. No.
Any sound?
Albert, kan du høre os?
I can hear you, yes.
Perfect. Okay, we move on then with Marianne's questions for your excellent talk. Thank you very much.
You hear me?
Yeah.
We hear you now. So I tried to repeat the question to you. And it was
No, I remember the question.
The authorities in the Netherlands, how you got the grant.
Well, we have a medicinal cannabis bureau in the Netherlands, and they work very closely to the Dutch government. It's part of the Dutch government. And one of their goals is to do research on cannabis. There are many parties in the Netherlands that were involved, but because of our initial study and our involvement with Bedrocan, we got that initial grant. But I have to say, the most important reason for doing research in cannabis in the Netherlands currently is that we all want to get rid of opioids. We see the opioid problem much, much larger than the cannabis problem. So all aims are at extending our therapeutic possibilities, either with non-opioid drugs like antidepressant, etc. But very interesting is to look at psychedelics, and cannabis is one of them. So it is an opportunity because of time and the fact that this medicinal bureau, cannabis bureau, had money available for one party. We were very fortunate that we got it. There were many other interested parties, but it's related to the kind of research we're doing, I guess.
And another question is, how is the physicians in the Netherlands, how do they accept this fact that you're studying the pain treatment to kind of find a new way to treat the patients, but also now it's cannabis, because there can be some kind of stigma by physicians and also resistance to treat. How do you see that in the Netherlands?
Well, that's a very relevant question, Marianne. And even within our own pain clinic, there are skeptics and there are people that do applaud us. So it is quite difficult. And because of the skepticism, the reimbursement of cannabis that was present in the Netherlands up till recently is lost. So patients that you treat outside of the study have to pay for cannabis themselves. But we do have pharmacies that are available. So the skepticism is quite high, but I have to say that people that are keen on improvement of patient care outside of the opioid realm, outside of opioids, they like it. They are not against it. But I'm fighting a little bit against these people, even within our own department. They're not a majority, I have to say. People do understand what we're doing. They do understand that it's important. So yeah, it's a big issue.
Another question, and that is related to the treatment with cannabis. Do you have developed in your society some treatment guidelines, or how do you handle the information to your physicians in the Netherlands so they can treat with cannabis? That's some questions that we have discussed here today. That would be nice to hear your perspectives from Canada around that, or from Netherlands about that.
Yeah, the Netherlands. Yeah, it's an important one, and I understand it. We had guidelines up till recently, but then we lost reimbursement, and the guidelines were taken out by. This is the guidelines initiated initially by GPs, which is the largest society in the Netherlands. But now we have our own SOP, standard operating procedures, and we work very close with a pharmacy that produces cannabis according to GMP. And in fact, when a patient comes to me with, for instance, neuropathic pain, I discuss it with the pharmacy. And a thing that we do is we contact the pharmacy, we tell them that we have this patient, and we can prescribe a certain variety from a list that the pharmacy has. And we are keen on currently on either we're using for these patients oils, for instance, CBD oil or THC oil, or the combination. For neuropathic pain, I like the combination somewhat more. The CBD component doesn't produce large pain relief, but it produces other symptoms. These people sleep better. Sleep is really important in treating pain patients. You need to realize that. So, so it's not really guidelines anymore. We will be developing guidelines within our grants, but it will take some time to get these guidelines back on. I was extremely disappointed by the loss of reimbursement. I've discussed this with many GPs, but it's the skepticism in some of them that prevented us from continuing this reimbursement. It's a political issue also. This was discussed in Parliament. My name was mentioned there several times because of the research that we're doing. But on my own, I cannot develop guidelines. I will be very honest with you. It's complex. It depends on the patient, the age of the patients, the complexity of the disease. I have my ideas about it, but I think we have to do this within the GP organization rather than by single physicians.
Then a question regarding your science that you just presented to us. It's in these specific pain patients. Do you see other areas where you think you would like to do some studies with medical cannabis?
Well, I will continue working, especially on neuropathic pain, which is the most complex form of pain. We're working on endogenous cannabinoids to enhance the endogenous cannabinoid system towards pain relief. These same cannabinoids are also strong, very strong anti-inflammatory agents. We're aiming at cancer pain. That's a big one. Not only chemotherapy-induced cancer pain, but also palliative care. So we're moving a little bit in scientifically away from the cannabis products that we currently have. We're working together with the chemistry lab to develop this agent that enhances endogenous products. So this is cancer pain, apart from neuropathic pain. But we also see, because we also started a program in post-traumatic stress disorder, in which we treat these patients now with ketamine-assisted psychotherapy. And there's also now the idea to move a little bit away from cannabis towards the combination of THC and CBD. The reason for that is that cannabis is very strong, and patients really dislike the psychedelic feelings. What we want an opening within psychotherapy, so they stop rumination, they allow us in. And I think that we can do this with cannabis. So there are many new venues, but cancer pain is most realistic currently, apart from neuropathic pain. I do not think it's a good treatment for acute pain. We've tried that and there was no effect. But possibly these endogenous cannabinoids will help us at one part. But the natural product is very, very active, and especially the THC component does really do a great job in pain.
And then I think the last question is that we also asked our former presenter from Canada, and it is if you should give some advices to Denmark around how to start up science like your own. You are a little bit ahead of us here. What would be your recommendation for good practices and what should we avoid?
Well, you know, one of the most important things, why were we so successful, is focus. Find a very focused research group that is able to do several of the parts that you need. You need a GMP facility. You need a good research group that is able to identify patients. You need to do phenotyping of patients. We really went for very strict in exclusion criteria. And one of the things that we did not want, didn't want a very fuzzy, a very broad patient population of different backgrounds. Focus. That is extremely helpful in our hands. And in the first stage, you know, decide on what kind of formulation you want. And then when you have the formulation, start testing different varieties. Come up with the best variety and continue. It's a stepwise process. And, you know, we've been working on this now for 5 years, and we only have one publication. So it doesn't really go fast. The second publication is what we're working on. I can give you a short glimpse. What we observed is that THC is active, but its metabolite, 11-hydroxy-THC, is 8 times more potent than THC in producing pain relief. And that was very surprising to us. So the next step will be that we will be talking to the companies that produce these compounds to see whether or not we can develop the hydroxy metabolites. Because what was quite interesting is that in terms of side effects, the 11-hydroxy had a 1/1 side effect profile compared to THC. So you can enhance the utility of the drug by using the metabolite. That will produce more pain relief with less side effects. And it's debatable. Some patients like these side effects, but there are patients that dislike it tremendously, and they were early terminators in the study. So I think we made progress in understanding how the drug works, and we will be focusing in the future on the metabolite, of course.
Thank you very much for the good questions, and thank you very much, Albert Dahan.
Thank you.
Thank you.
Actually, I have a few questions more for Albert, if he's still here. Yeah, because it's a question from the audience. They ask, how do you think that? Do you have any experience regarding effects on terpenes on the pain relief?
Yeah, that's a very good one, because we have the placebo, and the placebo contained terpenes. And I didn't show you the data, but I might have shown you that in terms of spontaneous pain relief, the terpenes by themselves had an appreciable analgesic effect. It did not surprise us because terpenes also interact with certain receptors. So terpenes by themselves have an effect, and the entourage effect, of course, is only present when you have terpenes on board. So terpenes are active analgesics.
Great. Great. And then there's a question we talked about earlier, the difference between medical cannabis and cannabis-based medicine. How do you in Holland, do you distinguish between these two, and how do you distinguish between these two? Both the policymakers, but also you as scientific workers.
Yeah, that's an important one. Non-medicinal cannabis is readily available here. You can buy it, even in the corona pandemic, it's readily available. And we have many patients that have an experience with non-medicinal cannabis. But we restrict medicinal cannabis currently, and we only obtain it from one company, that's Bedrocan in the Netherlands. And it's only available for 3 or 4 pharmacies. So it's extremely restricted to certain populations. But the other varieties available in coffee shops, etc., some are of very good quality. And the Dutch government is expanding the production of these non-medicinal cannabis varieties. But the problem with that is that we do not have any notion, any idea of the amount of THC and CBD in those varieties. And I think that is the first step. You really need to know what you're giving your patient. You want consistency. And the other problem is the quality of the product itself. How polluted is it? How well prepared is it, etc., etc. And another important one, we're all very much opposed to smoking. So that I liked the inhaled variety that we've used in the Nespresso cups, but there are also now indications that inhalation by itself might be less favorable. So we're moving away from that. That's why we're now aiming at tablets. But it's complex. Bioavailability is very different between the medicinal and the non-medicinal ones, between the inhaled and the tablets. So there's still lots of work to do.
Thank you very much. Thank you for your great talk and insights, and also thank you for answering these questions from Marianne and from the audience online.